Very close. So the average age is 66 years old. So this group. So this is correct. This is the average age of diagnosis with prostate cancer. It is extremely rare before the age of 40. Extremely rare. And that's due in large part to, of course, the fact that androgens are in large part to blame for the growth of prostate cancer. So this is what a normal prostate looks like.
Did we skip
The size and the shape, and what they're looking for when it changes are sort of hardened masses. Cancer and tumor, solid tumors are usually very hard, and they're very irregular. So they lose these perfectly symmetrical borders, and they become very, very dense and pressurized. Similar to what we might see in benign prostatic hyperplasia. So this is just an enlargement of the prostate. This is not prostate cancer. But the point is that the size of the prostate changes over time. So it changes from normal to a situation where you have benign prostatic hyperplasia. And the size of the prostate also grows rapidly during puberty. So during male puberty, the growth of the prostate is fueled by the rise in hormones, obviously called androgens in the body. Like I've said, like testosterone and dihydrotestosterone. And then it usually stays about the same size in adults. However, in younger men, the prostate is about the size of a walnut, but in older men, it can be a lot larger than that. And here I should mention this briefly, but you guys know this. These are the statistics for prostate cancer. The 5-year overall survival rate being 100%, the 10-year survival rate being 99%, the 15-year-old survival rate is 94%, and of all the cancers I've ever seen, ever read about, ever looked at, this is absolutely the best in terms of having a malignant type of cancer and having an outstanding survival rate. And this, in large part, is reflective of the way that we perceive treatment. So think about it this way. If you have a cancer where your 15-year survival rate is 94%, it's due to the fact that we've really optimized these treatment methods and made them tailored to the disease and a little bit less aggressive in how we would treat other types of cancers with very aggressive chemotherapy. This is a completely different approach, and also for a slow-growing cancer, primarily in older males. And so let's look briefly at the molecular events and pathogenesis. So for a lot of these things, I don't consider this to be heavy testable material for this audience. For this audience, I like to focus more on drugs and drug therapy and application of drugs. But there are some just basic things you might want to appreciate, that chromosomes are sort of lost and gained, and you have decreases in certain signaling proteins. And the decreases in the signaling proteins, these are stop proteins. So instead of stopping a lot of pathways, like the PI3 kinase AKT pathway, you get a loss of P10, so the off switch is gone. And then you also see decreases in NXX3.1, which is a negative regulator of cell growth, thus allowing cell growth, allowing cell proliferation, and cell survival. And then we have decreases in proteasomal proteins, so instead of these things being sent to the garbage can, now we have more cell cycle. So overall, we see increases in proliferation. So the cell morphology changes from normal prostate epithelium to full-blown prostate cancer. And when a pathologist is looking at slides, this is the type of thing that they're looking at. They're looking at the changes in morphology and shape, and they can really detect a lot of information by looking at cells. Okay, so this brings me to my next polling question, which is, done that one, which is, what is the estimated amount of time it takes for prostate cancer to fully develop? 1 to 2 years, 5 to 10 years, 15 to 20 years, or 20 to 30 years. This is what they hypothesize. They hypothesize that prostate cancers appear to develop over this particular period of time. And so things accumulate. These changes in chromosomes and genes and signaling proteins. How long is that? Okay, close. So again, it's 20 to 30 years. So they hypothesized that prostate cancer takes 20 to 30 years to develop. Again, I want to just point out and reemphasize slow growth this type of cancer in contrast to others that we're going to wrong. How would one know if they have symptoms of prostate cancer? Some of these overlap with benign prostatic hyperplasia. So, for example, a frequent need to urinate, especially at night. This could be a symptom, but this isn't something where we should overreact and automatically assume that there's a problem that's going to be diagnosed with prostate cancer. We also see difficulty starting or stopping a stream of urine, a weaker interrupted system, leaking, inability to urinate, continuous pain, burning sensation. But then what I have highlighted at the very bottom is blood in the urine. So for a lot of reasons, this is often the one that's most disconcerting and the biggest call to action in terms of like, maybe you need to go in for additional follow-up and additional check-ins and screening with a physician. One of the reasons why we see such low numbers, in addition to the fact that it's slow growing to develop, is also that we have early methods of detection. Not all cancers have early methods for detection, but in this case, we do have those for prostate cancer. We have the digital rectal exam and the prostate-specific antigen test. And we're going to talk about these two more on subsequent slides, but I want to highlight these first two because these are really involved in routine screening. So routine screening combines the digital rectal exam with the PSA. And so the digital rectal exam is visually depicted here, where you're trying to reach the prostate and get a feel of, is it hard, is it irregular, is it lumpy? And honestly, there's really no good way to access the prostate. Surgeons will say the same thing, in surgery, biopsies, it's really hard accessing it. And then we have other methods like the transrectal ultrasound. Now, this is typically done or it's used during a biopsy. So if there is a suspected case of prostate cancer and maybe they want to look further and get a biopsy specimen, this can be inserted and give a visual depiction of where the lesion is. So this little white dot that you see here to insert the needle to get a piece of this tissue so that the pathologist can look at it and assess whether or not it has signs of prostate cancer, whether it's malignant or whether it's benign. The transrectal MRI, this is really to assess, has cancer spread? The transrectal MRI is to assess, has cancer spread? Has it spread outside the prostate? Is it in other areas around here? Is it in the bone? That's really what that is used for. And then, of course, biopsy. Biopsy is really critical for prostate cancer because biopsy from the pathologist, they're going to check the tissue sample to see if there's any cancer cells, and they are going to assess the Gleeson score. And the Gleeson score is important because the Gleeson score gives us a really good idea of what you're managing clinically, what it is you have to treat. The Gleeson scores range from 2 all the way up to 10. And so we're going to define some ranges now. Unfortunately, I can't write on the slide with my pen, so I'm going to just verbally define them for you. So a Gleeson score of 2 to 4 means that you have a small tumor. So a Gleeson score from 2 to 4 means that you have a small tumor. It also means it's highly treatable. Very small prostate tumor, very highly treatable, from 2 to 4. Okay, so that's the Gleason score from 2 to 4. Now, if the Gleason score is 5 to 7, you have a treatable tumor. It may not be small, but it's still within that treatable spectrum. So a Gleason score from 5 to 7, you have a treatable tumor. If a Gleason score is from 8 to 10, so if a Gleason score is 8, if a Gleason score is 9, or if a Gleason score is 10, you have an advanced cancer. And advanced cancer is what it sounds like. Metastatic, advanced, and the 8, 9s, and 10s, this is where we don't know if we can achieve cure for these patients. Cure is not likely for a Gleason score of 8, 9, or 10. And again, so that's why these early tests are so important, to get that biopsy and to have that assessment by pathology. Okay, move on to the next slide. So here we're looking at the issues with the PSA test. So this is the prostate-specific antigen. PSA is secreted by normal prostatic endothelium, and it's also secreted by prostate cancer cells. So there is a normal level of PSA that is going to be detected in men. What you're looking for is the elevation. And initially, when PSA was approved in 1986, it was only approved to monitor progression of prostate cancer that was already diagnosed. So think of it as like a post-diagnosis biomarker. In 1986, when it was approved, that was really all it was designed to do. We have definitely broadened the definition and the usage of PSA since then, and so now we have situations of overdiagnosis and overtreatment. And so we have cautions within the new guidelines. And the new guidelines suggest there is a risk assessment where we should start talking about the risk and benefit of offering PSA. And this really depends on the age category that the individual is in. So if it's a male between the ages of 45 to 49, we might suggest, if the DRE is normal, PSA is a little high, to just repeat testing. The DRE is normal and the PSA is very low, and repeat testing at the age of 50 versus a couple of years. For those in the 50 to 70-year-old category, it gets a little tricky. If the DRE is normal, then we have a lot more questions about, well, what does PSA testing provide us? And for those over 70, we have cautions now where it's no longer recommended for those individuals to have PSA testing. This is very different to the strategy that we saw 5 years ago, which was every man should constantly have PSA exams routinely to see if there is a spike. We no longer have that recommendation. The recommendations have changed remarkably. And so, I want to jump to that slide, but I'll just go through this slide first. And so, what we see now is that PSA-based screening, it's changed because it significantly reduces mortality from prostate cancer, but does not affect all-cause mortality. So this is kind of a puzzling statistic, meaning you're less likely to die from prostate cancer, but you're not less likely to die. So imagine that. When you look at the cumulative hazard of death from prostate cancer in the screening group and the control group, again, we see some differences, but it doesn't affect all-cause mortality. And here I have just the cutoff levels of what we're looking for, over 3 and over 4 nanograms per ml. Now, the test doesn't have the sensitivity and specificity that would be required for a test for all other types of cancers. And so there are some issues with that. And here's what I wanted to jump to. These are the new established set of screening guidelines, and that is the very, very conservative American Urological Association, all the way to the less conservative, more liberal U.S. Preventative Services Task Force. So this is the government agency. And so the American Urological Association says that, yes, there should be shared decision-making, and that says for average risk patients, this should start at 40 years old for prostate cancer screening, but to discontinue it when life expectancy is less than 10 years. And the screening is PSA and DRE combined. So the frequency annually, and of course there's a criteria for biopsy referral. The American Cancer Society is somewhat in between these two groups, maybe a little bit more in line with the American Urological Association, because it says for average risk patients to start offering risk assessment at age 50. Discontinuation, all of this is very similar. Where the government U.S. Preventative Services Task Force cuts this off and says, do not screen patients with PSA for prostate cancer. And this is their recommendation. So if you actually go to their website and you look up PSA, they give it a grade of D. Not F, but they give it a grade of D. And so that's sort of the newer recommendation, not to perform this test. And that's probably also why from last year's cancer statistics to this year, there was a drop in 40,000 patients diagnosed with prostate cancer. It's probably due to the fact that these new recommendations have had time to percolate, and it's less likely that we are diagnosing those men with early stage prostate cancer. We're likely not diagnosing them. And again, the reason is because it's not clinically meaningful to them. It's not going to affect their mortality, whether they have it or whether they don't have it. Now, the combination of PSA and DRE was FDA approved in 1994 for screening of men for prostate cancer. But these were approved together. So PSA was never actually designed to be used alone on its own. Okay, so I have a couple of questions. I'm going to go to the next one. Okay, so what is the average life expectancy in years for a male living in the United States? What is the average life expectancy in years? So there should be a number to this answer. Number for a male living in the United States. And I'm asking this just to drive home the point of why we have the cutoff in PSA screening, why we set that age and what it's set at.
69. Is that what they're guessing?
I don't know. They said over 9,000. I said 70.
Very good, very good. The average age is 78 years. So you guys, the top responses were all around that. So excellent. So that's why we set the cutoff, even for the most conservative organizations, set the cutoff for PSA at age 70. Because if life expectancy is not greater than 10 years, greater than or equal to 10 years, we do not recommend the screening for cancer. It's not going to affect the mortality of that individual. And I point this out because this is a very, very different type of approach than what we're used to with cancer screening. I mean, other cancers, if there was any screening tool, you'd think that they would want to employ it. But in this situation, you have to temper that with patients and what we know about the disease and the disease biology. All right, so the treatment options for prostate cancer. Now we're going to start to get into more of the drug discussion. Well, yeah. Overdiagnosing. In 30 to 50% of all cases, we've been overdiagnosing. Okay, so the question was just, there's a little confusion about how dangerous. So let's say that you are a physician and you have a 75-year-old male patient. The question is, do you run the PSA? And if it came back at 4 nanograms per mil, what does that mean to that patient's life expectancy? And the recommendation is you would only run that test if you felt like that 75-year-old man who's incredibly healthy was going to live to be 80. And then it would.
So
Otherwise,
when you ask, can you please use the microphone? It means, can you please stop talking into the microphone in general?
yes, because the prostate cancer is not likely to cause mortality because it's so slow growing, so slow to evolve, and we have methods of treating it that it wouldn't affect their mortality. And so we consider those as you know, it's a really hard concept to get my mind wrapped around because you have these tools, but you don't use them.
Okay.
And you don't use them because
Sounds good to me.
you would be diagnosing a disease that's not going to affect your mortality. So if you diagnose that disease, what are you affecting? You're affecting their quality of life, right? And what you see clinically is the family, right? The family really cares because all they heard was, my loved one has cancer. And they equate that to something maybe on the brain. Then the clinician knows it's not. And I don't mean to minimize the fact that there are people with cancer. That's obviously what they do. That's not the majority. Like I said, I gave you guys 80%. 81% of the actual number, 80% of the rounded number of the men that come
Can we just leave since she's not actually speaking to us?
A very tiny.
Am I going to be
tumor
tested?
that's not going to- Did you know what the drop in 40,000? How do I know that? All right, so let me, I know that answer, I understand your question, but so last year we saw, I want to say like 200,000 prostate diagnosed with prostate cancer. And for the 2015,
Can you repeat the question?
the question's asking about the 40,000 drop, the 40,000 men drop in diagnosis.
Awesome.
And so this year, in the 2016 statistics, we saw, let's say, 160,000 men diagnosed with prostate cancer. And then when you read closer and you look at that statistic, it's due to the fact that we're not running PSA, we're not screening those men where it's not going to affect their life. We're just not doing it. And then again, we have these competing agencies where the government is saying, don't run it, don't do it, you're allowed to. And I don't
This is how
know
bad it is for every
how
other campus
that
when
affects
she's here. I
them.
wonder.
I don't know. If those agencies are looking for those recommendations. I don't know. This is that hard. You see these changes in guidelines. It never takes effect. Right? There's always this like lag. So for the past couple of years, they've been saying, don't screen, don't do it. Now it's like we see in the diagnosis. Okay, so the treatment options for prostate cancer. Okay, can you hear me better now? Can I do this? I just pull it, okay. I'll just pull it up closer. So stage 1, stage 2, and stage 3 low risk, meaning there's a very low risk that this would develop into metastatic disease. We do active surveillance. We can do prostatectomy. We can do radiotherapy, but we're not going to use chemotherapy. Chemotherapy would be a gross overtreatment of those patients. All the side effects that you guys can appreciate that come along with chemotherapy. Now, in stage 3 at high risk for becoming metastatic, and stage 4 disease, and also recurrent disease, we add androgen ablation to the standard treatment regimen using surgery, chemical castration. Here's where we also use chemotherapy. So we use everything we have in our arsenal against this particular type of disease. Okay, so with a stage 1 disease. This is where the tumor is found in the prostate only. For stage 2, it's in the prostate. It hasn't spread outside. Stage 2A, it's on one side of the prostate. Stage 2B, it's on all sides of the prostate. Stage 1, the Gleeson score would definitely be below 6. Without a doubt, for stage 1, your Gleeson score is below 6. And the PSA is below 10. For stage 2, the Gleeson score could be around 7, maybe 8, possibly around 7 to 8 for stage 2. And the PSA is below 20. Now, so stage 1, Gleason score is below 6. Stage 2, Gleason score is more around 7 to 8. Stage 3 and 4, it can be any Gleason score. It can be any PSA, although you can imagine that these are going to be pretty high. But stage 3 and stage 4 are staged on the basis of whether or not the disease has spread. So for stage 3, cancer has spread beyond the outer layer of the prostate. So here's the prostate. Here's where we see the spread for stage 3. So for stage 4, we see distant sites that have infiltration of prostate cancer. So the question is, when prostate cancer spreads to distant parts of the body, it invades in the lymph nodes, but what organ is its primary site? What organ is its primary destination? Anyone remember? Close. Bone. Excellent. Very good. So when prostate cancer metastasizes, it metastasizes primarily to the bone. So you're kind of seeing this right in here. It metastasizes to the bone. And of course, we have problems treating metastatic disease in general, but metastases to the bone, we don't have a methodology to cure or treat that particular type of disease. I mean, we can treat it, right? There are things that we can do, but we don't have the ability to cure that at this point. And when we consider stage 4, this is where the 5-year survival drops to 28%. And I think you see that in the last slide that I have in this lecture set. But that's where your survival rate really drops demonstrably to 28%. And so let's go further into the treatment options that we have for this disease. So for stage 1 or stage 2 prostate cancer, we have watchful waiting and active surveillance. So watchful waiting means that you closely monitor a patient without giving treatment until symptoms present themselves. For active surveillance, you are looking at a change in test results. So in watchful waiting, you're closely monitoring a patient's condition until symptoms appear or change. And then you're going to give treatment to relieve the symptoms to improve quality of life, versus active surveillance, where you're looking for a change in test results. And then, if and when you see the change in test results, then you act on it as far as treatment. We also have the options of radical prostatectomy, radiation therapy, and interstitial implantation of radioisotopes. So this is where you go in during surgery and you put in all these little radioisotopes around where the tumor site was that you removed, so that if there's any further growth of the tumor, it'll hit those radioactive isotopes, they open up, they release their radiation, and those cells will die off. So that's another option. But I don't obviously want to go into that in detail because we're focused on chemotherapy. Now, in terms of those men who chose watchful waiting, after 18 years, 60% have progressed. For those who chose radical prostatectomy after 18 years, 40% of those have progressed. So certainly the radical prostatectomy, there is a reduction in disease progression, of course, albeit after 18 years. But it doesn't go down to 0. And there's other concerns that we have for male quality of life with the prostatectomy. And when we look at the radical prostatectomy versus observation, we see that there is no significant difference in the proportion who died from prostate cancer. And then we see that the proportion that died from any cause, whether they had radical prostatectomy or observation, again, there was no significant difference. So what is this? This is a surgery that removes the prostate, the surrounding tissue, and the seminal vesicles. Lymph node removal could also occur during surgery, so this is before and this is after. Again, it's a very hard site to get to as a surgeon, and so this is why you see a lot of the equipment being touted for better surgical procedures for radical prostatectomy, the Da Vinci machine, in order to remove prostate. But of course, there are risks for every surgery. And in the case for radical prostatectomy, there are possible problems post-surgery. So when they looked at the group who had the procedure versus those that did not, they saw that there was an increase in the urinary incontinence, and there was an increase in erectile dysfunction, almost a doubling of that. There is a risk of impotence because surgery may impact the nerves controlling erections. There could also be, in addition to the urine leakage, there could be stool leakage, albeit this wasn't highly reported as different between the two groups. Inguinal hernia is a risk within the next 2 years. And for reasons that they do not understand, there is a slight shortening of the penis, only about 1 to 2 centimeters, but they have not figured out why that occurs post-surgery.
Some people need that.
So treatment options for stage 3 and stage 4 become more aggressive. So in addition to the radical prostatectomy, you also have hormonal therapy. You have external beam or internal radiation therapy, as well as hormonal therapy, or transurethral resection of the prostate. And for stage 4, we're also going to add bisphosphonate therapy to this group as well. And this is to reduce the bone disease when cancer has spread to the bone. Again, we can treat it, we can't cure it. And I just want to go through some of the hormonal therapies for prostate cancer. So hormonal therapy is the treatment that removes or blocks or inhibits the actions of testosterone and dihydrotestosterone, because the testosterone that's feeding the growth of these prostate cancer cells. And so you want to starve the cells of what's fueling them. Identical concept to breast cancer and estrogen, where estrogen in 80% of all cases is driving the growth of breast cancer cells. We have different methods of doing this for prostate cancer, and I've color-coded these according to their mechanism of action. So Leuprolide, for example, is a luteinizing hormone-releasing hormone agonist that stops the testicles from making testosterone, versus enzalutamide. This is an anti-androgen that binds the androgen receptor to inhibit binding and uptake of the androgen hormones like testosterone. So again, these are just color-coded according to their category and how they are acting. And for my toxicities for these, there was just no really good mascot that could visually depict gynecomastia, because it's one of those things that you just really have to see on a human to understand what is gynecomastia. So in 10% of patients that are taking flutamide, you see an enlargement of the male breast tissue due to a hormonal imbalance that, of course, develops when you're inhibiting the male androgens. And so I have this sun up here because 60% of the patients will experience hot flashes. So the sun is there to just illustrate hot flashes. And then this picture is here to demonstrate a decreased libido. Again, this is one thing I didn't know how to sort of visually depict in an animal. So 35% of men on flutamide will have a decreased libido. 30% of those will have impotence as well. And then nausea, vomiting, and diarrhea can also be associated with this. I understand this is a picture of a woman. I should have chosen a man. I'm didn't, or that don't take this medication. This is for men. I know it. And then also what you see here is that there is a discoloration of the urine secondary to the metabolism of flutamide. And then I have the liver here because there is an elevation of liver transamines in the serum. So when you see an elevation of liver enzymes, usually this suggests damage to the liver, right? Because liver enzymes should not be circulating, and if they are, that suggests damage because the membrane is becoming leaky, those liver cells, and so that's how they're getting in there. So let's contrast this with toxicities from goserelin. Similar in scale, a little bit different. So we have 50% of the men with hot flashes. We have 10% with gynecomastia, 20% with tumor flare. Again, this is something we can also see in tamoxifen with women. And then what I'm trying to denote here is this sort of inflammation and rash that occurs in sort of these areas where I have here on the legs and then on the arm. So this inflammation and rash. And then as far as decreased libido and impotence, we see this in 10%. So unlike flutamide, where we see this in a higher percent. Here, 10% of the patients will have impotence, and 10% of the patients will have decreased libido. But eventually what we know is that prostate cancer that's sensitive to androgens will become androgen insensitive. It's almost inevitable. It's just biology. And when they become insensitive to androgens, that's where we have androgen-independent prostate cancer, where they're getting signals from other receptors. They are changing the morphology and the binding between ligands. They're just amplifying the receptor. There are many, many mechanisms where this occurs, but eventually it can happen. And then when it does, we have recurrent disease. And with recurrent disease, we have to throw everything we have at the treatment. So that includes chemotherapy. It includes cyclophosphamide, biological therapy, hormonal therapy, radiation, and prostatectomy. And so the chemotherapy that we have for recurrent advanced prostate cancer is mitoxantrone, paclitaxel, docetaxel, etoposide, cabazitaxel, and vinblastine. So a number of these you have seen already and you should be familiar with. Now, category 1 to treat recurrence, metastatic disease, is docetaxel or enzalutamide. Category 1, again, that we have very large data sets and a lot of information to suggest that this is effective for this category of patients. So docetaxel or enzalutamide. But as you see, we have a number of different things that we can do. And this is for prior therapy with enzalutamide. We can go to docetaxel. Prior therapy with docetaxel, we can use enzalutamide, so we can interchange these. And then in addition, maybe cabazitaxel, radiation therapy. The point is that you have a lot of options. What I like to write for test material, though, is to really focus on docetaxel or enzalutamide, because I think it would be really hard to ask you to just memorize all these blocks in terms of like, what would a patient have? So just go with the standard answer, docetaxel or enzalutamide, and that's going to depend on what their prior therapy was, because we're talking about recurrent advanced disease in this case. I think we have previously talked about Provenge and cyclophosphamide, and this is where they take the white blood cells out of the patient, they expose them to antigens so that they would be able to recognize on the outside of the prostate cancer cells. Then they condition those white blood cells and they put them back inside the patient, and they do this to try to get the immune system recharged to recognize and fight off that cancer. But what we see is about 4 months of patient survival with the addition of cyclophosphamide. And as you probably know, this is a very, very expensive treatment. Its list price is $93,000, although I've said that it's very hard to find a patient that's actually spent $93,000 on this. And it's 3 treatments, 3 different time points. And again, it's for metastatic advanced disease, for which there is no cure, but something like sacraluzole T offers the advantage on average of about 4 months of additional survival. It's important to know that the outcome really depends on the stage of disease. So localized and regional cancer, the 5-year survival rate is about 100%. It's really those distant metastases where their survival rate drops significantly. And one time I had a graduate student, we got into a discussion where she's like, well, why are these patients dying then? I don't understand. And so we actually looked up a chart for the underlying cause of death for individuals that were diagnosed with prostate cancer. And it was stunning for us to see that there was an increase in things like heart failure, chronic lower respiratory diseases, external causes and accidents, falls, gastrointestinal disease, complications of heart disease, pulmonary circulation. So the point of this is that it's really all over the place. What was most disheartening to us was to see a 2-fold increase in the rate of suicide amongst men with prostate cancer as the underlying cause of death. And this just really hit home the point to us as far as maybe one reason why they're factoring in, why should we be diagnosing men with prostate cancer if it's not going to affect their mortality when you see a statistic like this in terms of the support and everything else that they're going to need and they're going through. And I don't really know the answer to that on how some of these social factors factor in, but it was just something that we started thinking and talking about. So, question in the back, and that's all for me. Well, it's hard for me to. I said something like that one time in the clinic, and I really got after this. No, you can't.